So, hello everyone, I'm Lade Smith, and I am here today with Professor Sir Robin Murray, who is, if you don't know who Robin Murray is, then you're probably not a psychiatrist watching this, because he is you are the world's most famous psychiatrist, I think, actually.
No.
Okay, one of the top three, anyway. And Robin has been if you work in psychiatry, much of the work that you do, especially with people with severe mental illness, Robin will have had something to do with the understanding that we have about those people. And Robin has very kindly agreed to have a chat with me today about psychosis, actually. Yep. And that's one of the main areas that I deal with in my everyday work. I work in South London, and South London is essentially Psychosis Centre of Europe, and Robin has done most of the research that helps us to understand what goes on with people who have psychosis. So I've got just a couple of questions for Robin, and I wanted us just to think about, number one, my first question is, if you're sitting at home watching this video and you're a psychiatrist, what would you want people to know about where we've come so far with psychosis?
Well, people are always saying that psychiatry is in crisis and things have never been so bad. All my life, people have been saying that. But when I look back, when I was a medical student, I spent 2 years working in a mental hospital in an old-fashioned asylum, and we did the physical examinations for the regular psychiatrists and got free board and lodging for that. But the people there were incarcerated for 10, 20 years. I have some old pictures, and you see everybody has got Parkinsonian movements, and so there's no doubt things are much better. These people had a terrible life. In the ward, where one of the wards I went, there was no toilet paper. People had to use a brush. And the charge nurse had a sock full of sand. Now we have terrible problems and so on, but it's as night is today. Okay. That things are so much better. I think the college has, well, actually when I came into psychiatry, spent some time fighting against the college because that's when, first of all, people had to sit an exam. Right. And I think that's one of the problems of the college, that many people, their first encounter with the college is when they have to pay money in order to sit an exam. So it takes some time to recover from this aversive experience.
Yeah, I think there probably is something about the college being relevant to people, actually. And I hope that the college could be more relevant to people, which is one of the reasons I'm talking to you, because I think that the college can really help to drive some of the innovation, but not necessarily innovation, more supporting the psychiatrists who can produce that innovation. And actually that's the job of the college as far as I'm concerned, certainly for academic psychiatrists. And I don't see any reason why there can't be regional hubs for academic psychiatrists. And so if you're a junior researcher in Manchester, you shouldn't have to come to London to further your career. There should be the ability to grow as a researcher in the Northwest. And likewise, if you want to do, if you're like me, a bit of a research active clinician, you should be able to.
I think the question of research active clinicians is important. If you think of people like oncologists or diabetologists, it's the natural thing that the clinician is involved in research projects. Yeah. And somehow or other in psychiatry, we've got the clinicians are often too run off their feet to be involved in research, and therefore the academics go it alone. But what I would like to see is a much closer link between the clinicians and the academics. So I think that is one thing I think the college could help with. But I think I feel that psychiatry, and our current president has been very good in this, but psychiatry has not had, or the college hasn't had, a tradition of being out and in the media all the time. I think that psychiatry goes by default often, and I think that one of our biggest issues is our relationship with our customers, with our patients.
Yeah.
And there's a lot of very fervent anti-psychiatrists who are maybe much better at Twitter and at appearing on the media to rubbish psychiatric treatment. And we need to be more out there advocating psychiatry, but also even advocating things like the way in which our children are brought up, or the environmental circumstances that our children are brought up. You mentioned, Lade, that South London is the capital of psychosis in Europe, and by that it's nothing to be proud of that we have the most psychosis per 100,000 of population of any city in which it's been recorded in Europe. And why is that? It's partly because the inner city is psychotogenic, that you may live in a tower block and your next door neighbour is a drug dealer. You're scared to walk down the street because you might get attacked by a gang, and you've had poor education. No wonder people go psychotic more frequently in the inner city. But what is psychiatry saying about this? I think that we need to be clearly more out and more media friendly. That's a thing you're very good at, actually. But I think that so there are many more things the college can do to support psychiatrists and the wider aspects of the mental health team, and liaise with the various charities, which I think has been a good thing in these recent years. Again, looking back in the bad old days, in the 1980s, I remember when Mind and the college used to spit at each other. They were so antagonistic, but now at least we have an alliance with more with most of the major charities. Yeah.
In fact, actually, I'm a trustee of Mind, of National Mind now. Actually, I think you're right. I mean, I'm going to slightly defend the college a little bit more. They've got a great strategic comms team now. And we can definitely use them. And there are people on Twitter who are staunch defenders of psychiatry. Rob Howard, Benjamin Janaway, he's a young trainee who really has put his head above the parapet. Who else do we have? Of course, Sami Huda, who does some brilliant work. And also we've got someone like Ahmed Hanke, who are really working to kind of diffuse stigma. But you're right, there is definitely more that the college could be doing, particularly around helping with psychoeducation and understanding that actually these are disorders, that they're really disorders, they're really illnesses. People are genuinely very disabled, often by particularly the severe mental illness. And the big thing for me is that these are disorders that 75% of mental illness arises before the age of 25. And we know that people who are young, if you cannot fulfill your potential, you drop out of university, it means you don't get the job you should get. If you don't get the job you should get, you may be unemployed. It means that, not only is it bad for you clinically, frankly, it's bad for the economy and it's bad for society, because you haven't got young people to look after the older people who need the support. And that lack of tax revenue is important to people who perhaps don't care about the clinical issues. But it's not just that, it's also the tax burden. And so it's a false economy not to invest in young people's mental health. And not just children, but young people full stop, and mental health full stop, because these are relapsing, remitting, often chronic disorders. I wanted to ask you a question, which was for working psychiatrists now. You told us about some of how things were before, and clearly things have much improved. But what should we be thinking about for the future? What's coming in psychosis?
Well, what I think is coming is an epidemic of cannabis-induced psychosis. In 1981, I remember talking to a diabetic physician, an expert in diabetes, and he said, all these fast food shops are opening, and people are eating more and more fast food. This is going to cause obesity and diabetes on a huge scale, and I was very skeptical about that. But I think now we are in danger of seeing the same thing for cannabis.
Yeah.
I'm not sure how widely it's known, but in South London, psychosis and schizophrenia are 3 times more common now than they were in the 1960s, and that's using the same criteria. And we have what we call high potency cannabis. That's 16% THC. When I talk to people in California or Colorado, they laugh at me and say, high potency, if only our people were smoking 15 or 16%. It's 40, 60, 80, 90% THC, and we tend to get America's bad habits. So whether we legalize or not, I think it's coming our way. So I think we have to be more proactive in terms of prevention, and it's great that the college now has a public health arm. But I think we have to think of all the ways in which society has developed in such a way as to exacerbate the difficulties for young people. So I think that would be one area I think we have to, it's a problem. But there are many good ways. I think the advent of cognitive behavior therapy, I think, has been a great thing, and it's mostly, although it was developed by a psychiatrist, that we've mostly handed it over to a psychologist. I think that, and it has also changed the way in which psychiatrists think about psychosis. Certainly I was taught that psychosis was a genetic brain disease, and Jaspers said you can't understand what people are saying. Therefore, you began to think, well, what's the point of trying to understand where the delusions and the hallucinations came from? But the CBT psychologists have taught us that is important. So I think the way that we function has changed, and so I think we should welcome all the insufficient able people in the mental health services. So we should welcome more expert psychologists, and if we can find some social workers, mostly disappeared, or occupational therapists. I think the difficulty for many psychiatrists is that they're forced. Their waiting list for psychology is 18 months. They trying to get help with housing for patients is very, very difficult. The occupational therapist has become a manager. So there's the psychiatrist, patient, and medication, and a queue of more people outside the door. So I think by default, psychiatrists have been pushed into practicing in a way that they don't like.
Yeah, that's right. You know, we do need the resources. I mean, you mentioned them all, and obviously that's underpinned by money, but it's not simply money. It's the staff and the training of the staff, etc. And if we don't have those, and we don't, you know, we have to argue for those. We've got really good evidence that we need these things. If we do not have them, then we cannot deliver the care that we're actually trained to do. It's not about reinventing what psychiatrists have to do. It's just about facilitating the situation, the environment, so that we can do our job properly. It's interesting you mentioned about cannabis. I mean, in our service, I was looking at the clinical informatics, and that's basically looking at, you know, what people, where the population need is, and what the diagnoses are and what the problems might be. This is a lot of Rob Harlan's work. What did we find? 99.7% of our patients, 99.7% have comorbid substance use problems, primarily cannabis. It used to be less than that, but these are all people who've been inpatients, who've been detained under section. And
so it's abnormal.
It's abnormal. I mean, I was thinking, who's the one person who didn't use cannabis? And the thing is that in the same time that has happened, our addiction services have just been decimated. Yeah. So we literally have, I've, in my psychiatry career, lived through a period of time where the growth of cannabis and substance use related disorders has gone up exponentially, and the demise of addiction psychiatry has gone downhill. And I imagine that if that addiction psychiatry continued, it wouldn't just be about looking, the model wouldn't just be one of looking after people with, opiate use disorders, that kind of model, which is the only way you can get in now. It would have spread to thinking about how do you manage harmful use of cannabis, because that's the main problem that our patients have.
Yeah, I think, well, to be fair, I think addiction services have at least got into cigarette smoking, and that's possible. But cannabis, I think, caught them unawares. So, as you may know, we've set up a cannabis and psychosis clinic here, or rather, my wife Marta DeForti has, and so patients come there who have both psychosis and cannabis use, and they meet each week virtually, and their results are fantastic actually. Many people, sometimes to their own surprise, manage to come off cannabis and do much better because of that.
But I think that's because of Marta actually. The question is, how do you distill Marta and then spread her around the country? That's the question.
I wouldn't, being her husband, I wouldn't be in favour of spreading her around. But I think one can have, one can set up, one can start setting up these clinics. And actually another thing which has been very good has been the development of the first episode intervention psychosis units, and I think people like them, patients like them, their relatives like them, the staff enjoy working in them, and if only the rest of psychiatry was as well staffed as that.
Therein lies a problem. It's always robbing pieces of paper. And actually, the model of early intervention should be what happens everywhere else. It shouldn't be that you take from generic services and give to everything else. And in fact, actually, what we really need to do is to really shore up generic services. It needs to be pump primed. It needs to be that it's not only okay, but being a general adult psychiatrist needs to be a prestige.
Yes.
It needs to be a prestige job. And for some reason over time it's become that actually it's better to go into something else and better to specialise, and I think that's been a real problem actually. I mean, I'm a general adult psychiatrist, and that's what makes me a better psychiatrist, having done general adult psychiatry for years and years and years, and now I do forensic work, but I think I'm a better forensic psychiatrist having been a general psychiatrist for most of my career.
But you are, in a sense, a general psychiatrist, and you look after psychotic people, but you have a particular area of interest, and I think that's the thing to have, and being involved in a research project or in some area of management or some area of audit, I think can give some people that particular expertise, and I think that's an important thing. There's no doubt the other area that we have a much better understanding of severe psychosis and schizophrenia than we had when I went into psychiatry. It was the textbooks were mostly full of nonsense about the causes of schizophrenia, and now we know that there's genetic predisposition. It's not you don't get a gene and bang you get psychotic, but we know the predisposition, we know the risk factors. We didn't know any of these risk factors when I was young, and it's a question, actually in some ways we have too many risk factors. We have early developmental insult, we have child abuse, we have migration, we have urbanicity, we have cannabis use. It's a question of understanding how they interact together. Something like coronary artery disease is also multifactorial, but you know how the risk factors for coronary artery disease, you know how the risk factors produce changes in lipids and hypertension and atheroma and clotting and so on. So but we're still missing that in psychiatry. But
Yeah.
I think with neuroscience is developing, and it hasn't quite had its big impact on psychiatry yet, but I think it will. And now, for example, there's a new generation of antipsychotics being developed, which aren't just dopamine blockers, or don't work primarily on the dopamine system. So my main complaint is that I'm not young enough to be able to see all these changes.
Yeah.
So
I'm sure you are actually, Robin.
I think the outlook for psychiatry and psychiatric understanding is tremendous, both from the biological, but also from the social and epidemiological point of view and psychological point of view.
Yeah, I agree. Well, Professor Sir Robin Murray, thank you very much for your time.
No, thank you, and best of luck in your candidacy for president.
Thank you.